All right, so here's what's going to happen. We have four processes in our respiratory system that are happening all the time. We have pulmonary ventilation, we have external respiration, internal respiration, and transport of gases. So we're on slide number 3 if you're following along in the slides, okay? So pulmonary ventilation is just breathing in and out. External respiration is when the gases are exchanging between the lungs and the blood, so think external. Pulling it in through the lungs into the blood, and then of course releasing the carbon dioxide. And then internal respiration is what we're doing at the tissues, right? Delivering the oxygen, picking up the carbon dioxide, and then we have to transport the gases. So those are four processes that are going to be happening all throughout, okay? Now you have two zones. You have the respiratory zone and you have the conducting zone. The respiratory zone is the area of the lungs where you have gas exchange, okay? So we're going to talk, that's the alveoli and these little respiratory bronchioles. We're going to talk about that. I'm going to try and figure out how I can maybe show pictures at some point, but today we're just going to try and get through this lecture. The conducting zone, what is it? It's what it sounds like. It's going to conduct the air to the respiratory zone. So things like your trachea and your bronchi, which we're going to talk about because we haven't covered that stuff in lab yet, but we shall today. All right, so functions of the nose really, really fast. It's an airway. It warms and moistens air. It filters and cleans the air. It's a resonating chamber. It serves to house the olfactory receptors, which are your sense of smell. Let's see if I can tap on this and make these things switch. Yeah, all right. Also, in the mucosa, you already know from the immune system, in the mucosa, you have defensins and lysosomes and things like that are antimicrobial. Right? We got hairs that trap some of those particles and things like that. And then also I think it's later in your notes here, but talking about cilia. All right, functions of the nasal conca. Those are the little, like when you look through the nasal passage of the skull, you can see the middle and the inferiors, right? Those little hook-like things, they're called turbinates as well. And that's to warm and moisten air. Okay, so filter, heat, and moisten air as you inhale, and then reclaim the heat and moisture as you exhale. This is all function stuff. I'm going to go fast because you do have the PowerPoints that when you're able to just look at them, even if you can't print them, you can read through that, okay? I want to actually turn this, how do I make this thing? There we go, okay. All right, I haven't figured out how to use this pen completely, so I use my finger. All right. As far as your sinuses, you have frontal, sphenoid, ethmoid, and maxillary. I'll go over those in lab. I actually have them on the video. I'll be referencing the video for that. Dysfunctions. Always no functions, always no dysfunctions, right? Rhinitis. It's inflammation. Rhine, always think nose. You know, if you hear the term rhinoplasty, it's nose surgery, right? Which I always find that term sort of offensive. Like you calling them a rhino? Like what's with the rhinoplasty? But anyway, when you hear rhine, you're going to think nose. And when you think plasty, of course, is surgery. But rhinitis means inflammation, right? So this is inflammation of the nasal cavity, which can get into the sinuses, and if that happens, it's called sinusitis. It can also get into the lower respiratory, and then you have a respiratory infection, right? If it gets down into the bronchi, all right. Does everybody like my shirt? Look, my barbarian shirt. This is for teaching specifically. I bought it specifically for teaching. I didn't. Okay. Let's see, let's pass the pharynx one because that's just different sections. That's anatomy. We are skipping to the slide that says larynx. I don't know if Friday people, you know this because I talked about this, but it is not called a larynx. There's no such thing as a larynx. And for some reason, it's a real pet peeve of mine when people are like, hey, the larynx. It's not a larynx, it's a larynx. And so the larynx is so you can see it here, that's my Adam's apple, which is actually the laryngeal prominence of the tracheal cartilage. You will learn that in lab, but it's your voice box, right? So it houses the vocal cords, and that's where we're going to be actually able to generate speech. What does that say, NAFU? What does that say? What does that mean? I don't know what that means. All right. By the way, you guys can ask questions, and I'll try to answer them. If we can save the questions towards the end, that would be better. But if you have questions along the way, just jump in, and if I don't catch it, please ask it again at the end. All right. Okay, so the larynx it has the vocal cords, but it's also an airway, right? It goes into the trachea, which is going to go down into the lungs, right into the bronchi of the lungs. We have it routes the food, right, and fluid, because there's a little flap. So there's a little flap. There's an opening called the glottis, okay? And then there's a little flap called the epiglottis. When you swallow, boop, the epiglottis flaps over, okay? Mine doesn't work a lot because I choke on, you know, stuff goes down the wrong pipe, right? Goes down the wrong pipe. That happens to me way too often. So I feel like I have a faulty epiglottis. I'm gonna try and trade it and get a new one. So the epiglottis is going to flap down and close off the airway. So the food goes into the esophagus, which is posterior to the trachea. All right, cool. If you look at that picture, by the way, so if you go to the next pic, whoops, damn it, I don't know how to go back with this stupid thing. But if you look at the picture, you can see the larynx, and if you go to the next picture, it's got the cross-sected, it's actually not a cross-section, it's actually a sagittal section, and you can see the vocal cords from the side there, okay? And if you look, and we're gonna go over this in lab, but the top vocal cords are the false ones and the bottom are the true when we're looking from the side view. When we're looking down, so let's see, if we go to the picture, well, we'll get there in a second, but if you go to the picture where you're looking down the throat, then on the inside, right, medial is gonna be those white bands of the true vocal cords, and lateral are the false vocal cords. False vocal cords don't produce any sound. So if you look on the next slide here, false vocal cords, all they do is they help close the glottis. The glottis is the opening, okay? Help close the glottis when you swallow. Right, so we have the epiglottis that flaps over, but also the vocal cords help kind of close that off as well. And so the vestibular folds, which are the false vocal cords. The true vocal cords don't do that. They vibrate as we push air through it, and they generate they generate sound, essentially. They generate your voice. Okay. Remember, the glottis is the opening between the vocal cords. So we switch to the next picture, right? Looks obscene. It's not. It's not what you think it is. That's looking down the throat, okay? And so you've got the white things are the true vocal cords, and they will open and close, right? As we push air through them, they will vibrate to generate sound, all right? Okay, as far as voice production, as I said, when we push air through the glottis, we're going to vibrate those vocal cords and generate sound. The pitch is determined by the length and tension that we put on those vocal cords. And then the loudness is how forcefully we push air through it, which I'm pretty good at because I'm loud. But I will tell you this, I don't think my aunt's gonna watch these, which is probably good, but she's way, way louder than me. She makes me seem like a church mouse, like super quiet, just saying. All right, just for the record, okay. So, amplify and enhance sound, things like the sinuses, things like your oral cavity, your nasal cavity, they're gonna amplify the sound. We shape the sound with things like our tongue and our hard palate and things like that, soft palate, lips, things like that. So there you go, all right? So again, I'm just kind of going through the key points on those slides. Valsalva maneuver, what is this thing? It's when we bear down, put pressure inside our abdomen. When do you do this? Well, when you go to the bathroom, you will do a Valsalva maneuver because it is it can empty the bowels, but of course it is used for other things. If I go to lift something heavy, right, I put pressure inside my abdominal cavity, that is a Valsalva maneuver. The reason it's here is because basically the glottis closes and puts this pressure in there, and it's talking about like this, the air, and so it has a respiratory component to it. But we use this as an orthopedic test. It actually checks to see if there's a disc involvement in the lower back. So if you put pressure in your abdomen like that, it would cause pain in the low back. Now you look at the bottom there, and it says something called Daydreams Triad. Daydreams Triad is force a cough, force a sneeze, bear down, do those three things. You have a patient do those three things and see if there's any pain. And if there is, there's a potential disc problem. You cannot diagnose a herniated disc from an orthopedic test. You would need an MRI, but anyway, this is just some extra facts that we need to make sure we're aware of. Okay, let's keep going. The trachealis muscle. Okay, so we'd have to go back to that picture. Remember looking? Oh, actually, no, I think the picture's on the next page. I don't know why I can't go back and forth with this thing, but I'm gonna figure out how to use this freaking keynote. But if you look on the picture, so it says trachealis muscle here. I think the picture's on the next page. I don't want to flip because I can't go back. Well, actually, I can flip. And so, yeah, it is. So you've got the esophagus, which is posterior. You've got the trachea, which is anterior. Between them, you have a little muscle called the trachealis. By the way, that takes care of the lab portion. That is the picture that I would use if I'm going to test trachealis. We do not have that on a model, okay? Pictures you are responsible for, but I will reference them, and I'll even pull some stuff up. Hopefully I can show you some good stuff. We'll see how the pictures show up when I do the lab later. I'm hoping that we can angle the camera just right. All right. Okay, so the trachealis muscle, what does it do? It helps expel the mucus, okay? And so when you cough. All right, let's keep going. I wish I could get out of this thing, but I can't. All right, we have the trachea that comes down, and at the bottom you have the last tracheal cartilage called the carina, and that is going to branch into primary bronchi, which branch into secondary bronchi, which branch into tertiary, and on. This happens about 23 times. For lab, you need to know primary, secondary, tertiary. And about the secondary, there are 2 that go to the left lung, 3 that go to the right, and that's because there's 2 lobes of the left lung, 3 on the right. Why are there more on the right? Well, because there is a notch on the left lung called the cardiac notch that makes space for the heart to kind of angle and sit. All right? So that takes care of a couple of the slides. I did a bunch of stuff right there, okay? Now, the bronchioles. So as we keep branching and branching and branching, they become really tiny ones. Remember arteries became arterioles? Venules, went into veins, right? If you went the other way, it would be veins going into venules, but of course the blood goes towards the heart. So veins are little venules, arterioles are little arteries, and bronchioles are little bronchi. And by the way, bronchi is plural, bronchus is singular. I never take off for a lab exam on stuff like that, so I'm not too worried about plurals, but just be aware of it. When it gets to be less than a millimeter, then it's called the bronchiole, all right? Let's go to the slide that says respiratory zone up at the top, and it talks about there is approximately 300 million alveoli per lung. A lot of alveoli. The alveoli are that site of gas exchange. Okay, that's where we're going to see the gas exchange happening. I'm very sad I didn't bring my Hoberman ball home. I have that ball that expands. Friday, people, you saw it. You get to see this. Tuesday, Thursday, people, don't have it. Can't get into my office. But basically, I use that for a couple of examples, but one to see the expansion of the alveoli, right? There's these sacs. So if you look at the pictures in your lab manual and your textbook, you'll see that it looks like a cluster of grapes, and those little grapes, each one is an alveolus, and plural is alveoli, and that is where the gas exchange is going to happen, okay? And even if we go to the next slide, you can see the alveoli, and the slide after that, you can see the network of capillaries around the alveoli. Now, some important stuff here. Alveoli, if you remember from 201, which you don't, but if you did, you'd remember that it is a simple squamous, right? It's flat cells, right? So the type 1 cells are simple squamous. Simple means one cell layer, squamous means flat. Why? Because we need to transfer things across it. So we want to make it thin, right? And not multiple layers, right? These flat cells. And so that's effective. But embedded within that wall of simple squamous, you have these type 2 alveolar cells. And these guys are important for a couple of things. One thing, they're going to produce some antimicrobial proteins, which I'm not going to ask you on a test, but that's kind of cool that they do that. The second thing, and the most important thing about these type 2 cells, is they secrete surfactant. I saw a comment on Italians. I don't know what, you guys are having your own little conversation. All right, so what, you got a problem with Italians over here? All right, so surfactant is the chemical that reduces surface tension. What's that? I don't know, you guys got to figure that out. I'm kidding. Surfactant is this stuff that if you think of this grape, let's take an alveoli, we'll blow it up, and we'll take the inside of it, right? These cells are producing this fluid, this surfactant, right? And this fluid coats the inside of the alveoli. That reduces surface tension. Well, what the heck does that mean? Well, there's a tension on the alveoli, right, on the lungs, because there's going to be a sac outside the lungs, okay? And that's going to create pressure, right? It's called a pleural cavity. And so there's pressure inside there. And we want to make sure the pressure inside is greater than the pressure outside. Now, that being said, what this surfactant does is it reduces the tension on the surface that will cause lung collapse. If we don't produce surfactant, the lungs would collapse. So really important stuff. When babies can't breathe yet, right? They haven't developed the ability to breathe or keep their lungs inflated. It's because they can't produce surfactant yet. All right, let's keep going. I already talked about the lobes and the cardiac notch. Oh, take a look at I can't go back. Take a look at the picture on that guy's face. Look how happy he looks. Anyway, all right, let's keep moving. If we go, I'm gonna get out of this and go back in because I can't stand not being able to go back. So give me a minute here, guys. Any questions so far? Let's take a pause for questions while I'm resetting my PowerPoint. Anybody? Oh, you mother. It didn't do it. Just reset, dude. Maybe I'll go into Canvas and access it from there, but let's see. Okay. We're cranking through the notes. We're doing good here. All right. We left off. Yeah, look at the guy's face. For reals. That's about how happy I feel about this online thing. I'm just kidding. It's going to be good. All right. So let's go to pulmonary circulation. All right. Let's see. What was the trachea order again? Like the branching? I think you're asking about the branching. It goes trachea to primary bronchi. Primaries go into secondaries, and secondaries go into tertiaries. And that's just, it's going to go 23 times, but that's as far as I take it for lab purposes, okay? You said you want to make sure pressure inside is greater than outside. That is correct. And I'm going to get into that, Amanda. I think it's, yeah, it says Amanda. Okay. I'm going to get into that in a little bit. The pressures, yes, the pressure in the alveoli, which is called intrapulmonary pressure or intra-alveolar pressure, must be greater than the intrapleural pressure, which is the pressure in the sac outside the lungs. Okay. Now, hopefully I answered those questions. If not, ask them again, all right, or ask for clarification. Now, we've got pulmonary arteries and pulmonary veins. We know this already. This is the pulmonary circulation. This does not feed the lungs. This is a review of what we covered in the blood chapter, okay? Or actually it was in the circulatory chapter. And we know that the pulmonary arteries go away, arteries go away from the heart chambers, and veins go towards heart chambers. So the pulmonary arteries took blood to the lungs. We filled up that blood with nice oxygen, and we brought that blood back to the heart through pulmonary veins. That is the pulmonary circuit. Okay, remember pulmonary trunk, pulmonary arteries, back through pulmonary veins. Now, there is something called the bronchial circulation. Okay. Oh, by the way, if you look on that slide too, down at the bottom, it talks about the ACE, the angiotensin converting enzyme, the thing that converted angiotensin 1 to 2. We'll be talking about that again in the future, but here is where it's made, in the pleura of the lungs, and or the endothelium of the lungs, actually. And okay, so now it doesn't want to switch. Okay, this thing's being a little bit of a pain, but we'll figure it out. Bronchial arteries. What are these guys? Well, bronchial, you're going to think lungs, because we just talked about bronchi and bronchioles and all that stuff. Well, bronchial circulation is simply the supply to the lungs, the lung tissue. So arteries supply tissues, right, and veins drain them. So bronchial arteries supply the lung tissues. Bronchial veins drain the lung tissues. And the only thing that got confusing about, I don't want you to get confused on this because it's not going to be on the test, but the bronchial veins are going to merge with the pulmonary veins. Now, pulmonary veins are filled with oxygenated blood because we just came back from the lungs with them, filling them up with oxygen, okay, the blood and the blood cells. The bronchial veins need to get back to the heart, so the easiest way to do it is they just anastomose with the pulmonary veins. The bronchial veins put a little bit of deoxygenated blood in the pulmonary veins that are filled with oxygenated blood. Again, don't worry about that too much. I'm just explaining it because it's in your notes and it's kind of, you should know it. Don't stress on that for testing. It won't be on the test. Now, but what should you know for the test? I don't know if this is on your test, but you should know that bronchial circulation supplies the lungs, just like coronary circulation supplied the heart. Make sense? Say yes? Good. All right. I'm pretending you all said yes. All right, so let's talk about these coverings of the heart. We've got pleura. It's not the heart, about the lungs. Yeah, I'm going to make like a gazillion mistakes. This is cool. All right, so the covering of the heart was the pericardium. Remember that? Peri means around, next to, or near. We're going to have coverings of the lungs and the thoracic cavity as well. This stuff is called pleura. When we get to the abdomen, we call it peritoneum. So we have different names for it in different sections, okay? The question here is bronchial veins drain. I don't know why I read pulmonary. I got to slow down a little bit. Bronchial veins drain lung tissues. That is correct. So bronchial arteries supply oxygen to lung tissues. Bronchial veins drain the deoxygenated blood from lung tissues to get it back to the heart. Okay. All right. So back to the pleura. We have parietal pleura, and we have visceral pleura. Visceral, you think organ, right? Yes. Say yes. Say yes. Gosh, guys. So visceral, I wonder if I'm gonna lose my mind doing this freaking like, this looks like a one-on-one talking to my twin. So the visceral pleura covers the organs. What's the organ in the thoracic? Besides the heart has its own. C, thank you. The lungs are the organ in the thoracic cavity, right? Because the heart has the pericardium, this has the pleura. So the visceral pleura directly covers the lungs. The parietal pleura covers the thoracic wall. Here's the thing, it's one layer. It's just folded over. So if you look at the picture, let's go to the picture on the next page where it's got a cross section there and you're looking down, okay? So you've got, I'm trying to read the comments at the same time. So you've got the covering, if you look on the inside there, you've got the covering on the wall of the thoracic cavity, and then you get the covering on the lungs. It's continuous. Why is this important? Well, it's important because that means if it's really one layer folded over like that, that means it creates a cavity. And that cavity is called the pleural cavity. What kind of fluid do you think we're gonna have in there? Pleural fluid, okay? So, and we'll talk more about that because we're gonna get into the whole pressures and all that stuff later, okay? Next slide says inspiration and expiration. I hope you know what that means. Inspiration, you breathe in. Expiration, you breathe out. We're not going to cover that. Okay. I'll make sure to miss any questions here. All right. So let's talk about pressures. This is where we get super duper important. And I think what I'm going to do, I'm going to, let's see. I want to just figure something out here where I can write. But let's just keep going for now. Maybe I think if I get a pad and put it up, it's going to be reversed also, though. That's the only problem. Whatever you see is going to be reversed. Anyway, I don't know. I'm going to keep brainstorming this stuff. Okay, so atmospheric pressure, what is it? It's the pressure in the atmosphere. It's the pressure outside the body, okay? When you hear a weatherman talk about the barometric pressure, right? It's measured with a barometer. It's actually talking about atmospheric pressure. All right, so now we're going to need to, we use atmospheric pressure as a reference when we're talking about breathing because we're going to have to manipulate our inside pressure in reference to atmospheric pressure to get air in and out. So we're going to establish some principles. The first thing we want to talk about is that we have this terminology, okay? If you look at the bottom there, it says negative, positive, and zero respiratory pressure. Well, zero is when your when any pressure, right? If we're using any pressure to compare to atmospheric, when it is equal to atmospheric pressure, we call it zero pressure. When it is greater, we call it positive respiratory pressure. And when it is less than, we call it negative respiratory pressure, okay? Keep those things in mind because we'll be talking about that. When we talk about the intra-alveolar pressure, which is also known as intrapulmonary pressure, they're the same thing, inside the lungs. We're going to be referencing the pressure there compared to the atmospheric pressure. And you're going to see that the pressure is going to be equal, which is zero. It's going to be lower, which is negative pressure. And it's going to be greater, which is positive pressure. So it's going to be all of those at different points in time. Hey, look, a kettlebell. Okay. All right. Let's see. Okay, go to the next slide. It talks about the intrapulmonary and intraalveolar, which is intraalveolar pressure, okay? It says fluctuates with breathing, its pressure inside the alveoli, okay? So inside the lungs. Intrapleural pressure, well, intra means within. Pleural, we know what the pleural cavity is. It's that cavity I just told you was the double layer that made a sac, and so that's gonna be the pressure inside of there, all right? All right, let's keep going and we'll talk more about that stuff. There's something called transpulmonary pressure. Transpulmonary pressure is essentially the pressure that, if you take the pressure inside the lungs, intraalveolar, and you minus the pressure inside the sac outside the lungs, which is intrapleural, you get your transpulmonary pressure. What you want to understand is that the transpulmonary pressure must always be greater than zero, okay? It must always be greater than zero. If the transpulmonary pressure is not greater than zero, what do you think happens? The lungs are going to collapse. So think about this. If the pressure in the pleural cavity, the sac outside the lungs, equals the pressure inside the lungs are unable to inflate. They will collapse. Lung collapse is called atelectasis. We go to the next slide. Okay. Now, a lot of times, like EMTs and paramedics, they talk about pneumothorax and atelectasis as if they're synonyms. They are not. They use that because oftentimes they're dealing with pneumothorax. Pneumothorax is probably the most common cause of atelectasis. So I'll explain what that is in a moment. But atelectasis is just lung collapse. It can happen if you have plugged bronchioles. okay, if you see there. It can also happen if you have pneumothorax or something called hemothorax, okay? If you think about this, if you get a puncture wound, okay, what's going to happen is if you puncture that sac outside the lungs, okay, air is going to get in there, or air can get in there, all right? And if air gets in the pleural cavity, now air is a substance. We learned this when we talked about blood pressures. If you take a substance and you put more of a substance, any substance, in a container, it increases the pressure in that container, right? So if we take air, a substance, and we put it in the pleural cavity that has pleural fluid, but now we're putting air in it too, the pressure inside the pleural cavity, the intrapleural pressure, will increase. So what's going to happen? The intrapleural pressure is going to exceed the intrapulmonary pressure, and the lungs will collapse, okay? And the cause is pneumothorax. Pneumo means, PNE means breath. So pneumothorax is the air inside the pleural cavity. Hemothorax is just that blood gets in there, so also. Now, what you would do is you could put a chest tube in, and it would actually remove the air from the pleural cavity. And that's it, okay? No MacGyver. Don't take a pen and jam it in and try and, okay? By the way, if you put a chest tube in, you will hear the air coming out of it, actually. It's pretty interesting. Sometimes fluid as well. But what's going to happen is when you put that chest tube in and the pressure goes down inside the pleural cavity, the lungs reinflate, right? Because the pressure inside is now greater than the pressure outside. All right, how we doing? Any questions so far? Anybody? Somebody? All right, I should be sitting on a more comfortable chair. I got to get my office chair next time. All right. If we go to the next slide, okay, the principle on this slide. It's a lot of words on that slide. Here's what you need. Here's the takeaway for it, okay? I want to try and condense concepts for you sometimes here, and this is what I'm doing right now on this slide. Particles move from what to what? They move from high to low, right? High concentration to low concentration. Sodium likes to move from high sodium to low sodium. Potassium likes to move from high potassium to low potassium. These are things we'll talk about more in the future. Pressure does the same type of thing. It moves, so that's called moving, by the way, the sodium potassium is called moving down the concentration gradient, right? Going from high to low. Well, pressure, air moves down the pressure gradient. So it moves from high pressure to low pressure, okay? So air is always going, that's the takeaway from this slide. Air is always, or gases are always going to move from high to low pressure. That's it. They're going to move from high to low. All right? We're going to take that concept and we're going to be using it very shortly to explain this lung physiology. Okay. Boyle's law. Here's what you want to know about Boyle's law. Boyle's law essentially is going to tell you that if I change volume of the container, I change the pressure in that container. This makes sense, and you should have this kind of in your head already. Remember I talked about take all the blood vessels, make a big rubber container. Take the container and boop, expand the container. What happens to the pressure inside? It drops. What do I do if I contract the container, right? The blood vessels vasoconstrict. I increase the pressure inside the container, raising the blood pressure. We just have different container and different substance. So instead of blood and blood vessels, what we have is lungs and air. And so the V, so you see P1 times V1 equals P2 times V2, okay? What that is the pressure inside the lungs times the volume of the lungs, the container, the lungs, not the volume of the substance, equals the pressure times the volume of the lungs in a different state. So for instance, if this is my lungs, if these are my lungs, okay, take a point anywhere. Stop right there, okay? And then stop right there. Take those 2 points, measure the volume, measure the pressure, times the product of each. They will be equal, okay? I will not have you do calculations on an exam or quiz. The reason I'm telling you this is this law of changing volume causes changes in pressure, or changing volume of the container causes changes in pressure. This tells you that if I manipulate my lung volume, I can change the pressure. Why is that important? Well, we just established on the last slide that in order to get air to move, it goes from high to low. So if you want air in the lungs, what do you have to do to the lungs? So now let's go back to those terminologies, right? We said that atmospheric pressure, if I want to get less than atmospheric pressure, it's called negative pressure, right? So in order to get air to go into the lungs, we have to get the pressure inside the lungs to be a negative pressure, right? Why? because air moves from high to low. So if atmospheric is higher and inside is lower, air moves from out to in. That's how we get air in the lungs, okay? If I want to get air out of the lungs, I have to make the pressure inside the lungs higher than the atmospheric pressure, and then the air moves from high inside to low outside. How do we do that? We manipulate the volume. So like I said, you're going to see a change in pressures of the intra-alveolar, aka intrapulmonary pressure, as we change the volume of the lungs, all right? It's a lot to take in, but we're going to be going over it again, all right? Now, if you go to the next slide, it talks about the diaphragm and external intercostals. Now, these are your inspiratory muscles. These are the muscles. we're going to transition for a second because I need a back for my, hopefully I don't drop everything. Okay. All right. Hold on one second, coming back. All right, better. Okay. All right. So if we're looking on the slide, diaphragm is responsible for 75% of your inspiration, and your external intercostals are responsible for about 25% of inspiration. This is normal inspiration, even somewhat above normal, and I'm going to talk about that in a minute. But memorize those numbers. I want you to know that. I also want you to know that the muscles that are active during normal inspiration, which is called your tidal volume, those are the two muscles. Those are the two muscles that are active, the diaphragm and the external intercostals. Now here's what happens. The diaphragm is a sheet that lays over the abdominal organs. It is at the base of the lungs. I'm going to just go here, pretend this is my lungs. Okay? It's over the abdominal organs. It's going to compress the abdominal organs when it contracts. Why is it doing that? It's making space for the lungs to expand. It's going to expand the thoracic cavity, which is attached pleurally to the lungs, which is going to expand the lungs. So that's what the diaphragm does. So when it contracts, this is a good test question. When it contracts, it moves inferior. When it relaxes, it moves superior. Okay? The diaphragm. The external intercostals, we think intercostals are between the ribs, right? The costals. Remember from 201 that muscles contract along the angle of the fibers. So if we don't think about it too much, we think, oh, intercostals are going to pull the ribs together. Incorrect. Internal will. External intercostals, the angle goes this way. Internals, they go this way. Okay? So the angle of the fibers for external intercostals go this way. So what it's going to do when they contract is it pulls the rib cage up and out. So when I breathe in, a lot of people get confused on the diaphragm thing because when I breathe in, my rib cage goes up. So people think, oh, the diaphragm goes up. No, the diaphragm pushes down. The external intercostals pull the rib cage up and out. Okay, so that's now what's the goal of that? To expand the rib cage, to expand the thoracic cavity, to expand the lungs. Again, manipulating the volume of the lungs manipulates the pressure in the lungs. I have a question here. Let's see. Resting state diaphragm stays up. I don't know what resting state diaphragm means. Oh, in resting state. Is that what you're saying? In the resting state? Yeah, it's relaxed. Yeah, it's just, so when it's relaxed, the diaphragm's here, and then when we breathe in, it pushes down. When I breathe out, it goes back up, if that makes sense. The important thing to know, okay, cool. The important thing to know is that the diaphragm moves inferiorly when it contracts, and it moves superiorly when it relaxes. The external intercostals pull the rib cage up and out when it contracts, and it allows the rib cage to fall back down when you relax, the external intercostals. Okay? Don't get confused on this. External intercostals are for inspiration. A lot of times we think external expiration or internal inspiration. No, it doesn't work that way. All right, so pay attention to what I was saying about the angle of the fibers. Okay, now if you look on this slide, I want to make sure we don't get confused on it. It says thoracic volume increases, intrapulmonary pressure drops to -1 millimeters of mercury. Now, if you go back to the atmospheric pressure slide, it says that the atmospheric pressure at sea level is about 760 millimeters of mercury. This is not saying you're dropping from 760 down to -1. Here's what this is saying. Okay, don't worry about the -1. Erase it from your brain. Here's what it's saying. You have to get a negative pressure to get air in. That's what the -1 is. You need a negative pressure. So in other words, if this is atmospheric pressure and this is my intrapulmonary, I have to get the pressure of the intrapulmonary pressure lower than atmospheric. So as I drop lower than atmospheric pressure, air starts to go into the lungs. That's what it's saying. All right? Okay, so now let's do this inspiration thing. What's going to happen? As I breathe in, the external intercostals contract, pulling the rib cage up and out. The diaphragm pushes down, okay, pushing the abdominal organs out of the way. What we're doing is we're expanding the thoracic cavity. When we expand the thoracic cavity, the lungs will also expand. So now what we've done is we've expanded the container. What do we say about expanding the container? If I expand the container, what happens to the pressure in that container? Boop, it drops, right? So the pressure in the container drops. What's going to happen? Well, once it drops below the pressure outside the body, the atmospheric pressure, air is going to move from the outside to the inside, okay? So hopefully that makes sense. And we're going to talk more about this. Now, I'm going to show you a pressure gradient. Okay, hold on a second. Holy crap. Okay. These videos are going to be freaking comical. Hold on, I need to get a prop. Hold on. All right. I vote that the school buy me like all of the anatomical models. That's my vote. All right, here we go. So we've got red, atmospheric pressure, right? Let's go with this. We've got blue, that's gonna be my intrapulmonary pressure, all right? What do we have to do, intrapulmonary, atmospheric? What do we have to do to get air to go in? I've got to drop the intrapulmonary below the atmospheric. How do I do that? By expanding the container, right? Because if volume goes up, pressure goes down. This is of the container, right? Container gets smaller, pressure goes up, okay? Now I'm gonna show you kind of like a pressure scale, okay? This is what's gonna happen on a pressure scale. Atmospheric pressure is not gonna change. I mean, if you're climbing up a mountain, it will, and we'll talk about that. Somebody remind me if I don't talk about the mountain. And we only got about 15 minutes left here, but we need to do this. So if we have atmospheric pressure, it's going to be constant, right? Relatively constant. So this is going to be my intrapulmonary pressure. So what's going to happen is when I breathe in and I contract those muscles, it's going to expand the container and it's going to drop the pressure, right? Air is going to flood into the lungs. So watch this. It's going to go like this, and I'm going to explain it in a second. It's going to go like this. As I breathe in. Okay. I don't know why I'm pursing my lips. That's retarded. But anyway, just kidding. So I can't stop doing it. Apparently that's how I breathe in. Don't you all make fun of me. All right. So here's the thing. As I drop, I'm never going to stop doing it. As I drop the pressure. Do I do that in class? Friday, people, did I do that? That looks idiotic. Okay. So as I drop the pressure, air floods in. So what the heck is this? Why am I coming back up to zero pressure? This is zero pressure, right? I breathe in, I breathe in, and I'm gonna drop the pressure inside and air is gonna go in, right? What's gonna happen? Substance is going in the container. So I go from zero pressure to negative pressure, right? I did it without pursing. Okay. I did it again, damn it. Okay. And then, as air floods into the lungs, what happens? As I put substance, volume of fluid or material or air, whatever, volume of something, of the substance, into the container, the pressure goes up. Remember, let's go back to the blood real quick. When we talked about the container, we said, hey, if we change volume of the blood, we change pressure. We put more fluid in, pressure goes up. We take fluid out, pressure goes down, right? This is the same thing, except we're talking about air. So what's going to happen is, as I breathe in, I don't want to do it anymore. As I breathe in, again, that's a very baby purse, right? Right? So as I'm going here, I'm expanding the container and air starts to flood in. And as air floods in, it brings me back to zero pressure. Does that make sense? Somebody tell me if it makes sense. I don't want to move on unless we're this is jiving. I want to make sure we're like clicking. Yeah? Anybody? Somebody? I'm still laughing at my pursed lips with my breathing. All right. Okay. So nobody's going to answer me. Perfect. All right. Awesome. Fantastic. This is great. All right. Thank you. Thank you. I don't know who that is, but whoever gave me that thumbs up. All right. You as well. Thank you so much. Okay. So here's what's going to happen, right? As I breathe in, and then I breathe out. I didn't even get to that part yet, but we'll get there, okay? That's my pressure gradient. As this is happening, I want you to visualize the lungs are expanding and then air starts to go in the lungs. As the lungs, when the lungs stop expanding, as the air fills the lungs, right, it brings the pressure back up. When do we stop? Okay, so when do I stop with the inhalation? I stop when there's zero pressure. Why? Air doesn't move when there's zero pressure because it's the same. It moves from high to low, right? So if I go, air's moving from high to low. As air moves in and it brings the pressure back to zero, no more air movement, all right? Now, let's just do the reverse. It's on the next, well, I guess we can go to the other slide, but not just jump ahead 2 slides. We'll go back to that other one in a second. Wait, we got to jump a few more slides. Go to the exhalation one. That's the inhalation picture, which is nice. Go to it says expiration up at the upper left, or you can go to the picture that's got the expiration and the picture of the lungs, either one. That's this. So what's happening? When I go here, I'm relaxing the diaphragm. That was very intense. I'm relaxing the diaphragm. I'm relaxing the external intercostals. So what's happening? The diaphragm comes back up, making the container smaller. The rib cage comes back down, relaxing the external intercostals, making the container smaller. When I make the container smaller, the lungs are smaller, right? When they're smaller, when they decrease in volume of the container, the pressure goes up, okay? So here we go. Hold that question for a second, Amanda. I'll look at it in a moment. But I go, as I breathe out, the muscles are relaxing, right? I should say, as the muscles are relaxing, the container is getting smaller. Watch this. This is the container getting smaller. Where does pressure move? From high to low. So now it's going from the inside to the outside. And as the air moves out, we come back down to zero pressure. Are you with me? Okay, let me see what this question is. Think about if you have any questions. So when you hold your breath, are you strengthening the muscles or the lungs themselves? It depends on what you're doing exactly. Like, I don't know if you've seen my video on Wim Hof breathing, but that does strengthen the lung. It strengthens the lung muscles. It strengthens the inspiration muscles, the inspiratory muscles. So I don't know if that answers your question, but you can, and it helps expand the lungs more and more as those muscles get stronger. So I wouldn't say necessarily holding your breath does that, but with the Wim Hof breathing, you do this like cycle of breathing and then you hold it for as long as you can, and that is very effective for strengthening those muscles, as well as a number of other things. And there's other types of breathing exercises. I have this little, it's called a breather, and it inhibits the airway, and you do like 3 sets of 10 or something, and it's also, and you can go both directions, so it can strengthen inspiratory and expiratory muscles that are active. And we haven't talked about all the muscles yet, but we're about to. Okay, we talked about just the ones for normal inspiration. What about when you're swimming? Well, it's going to be like anything else. Any kind of exercise is going to increase not only your cardiovascular output, but it's going to increase your lung output. So yes, that will strengthen those muscles as well. And really, any type of exercise is going to do that, to be completely honest with you. Unless you're walking, which is not exercise, AKA not exercise. No, it might be for some people if you're power walking, right? Where you look like you're playing the maracas. Anyway, I use the power walk sometimes in addition to my training. Anyway, it looked really cool. I would wear my shorty shorts and it would be amazing. Anyway, that's not true. Okay, so none of it. I did power walk though at times. It's the only part that was true. Okay, so let's get back to the material. So we need these mental breaks. But we have only 10 minutes, so we're gonna kick some ass here and do the rest of this physiology portion. So let's get back to the muscles. Let's get back to the inspiration part, okay? I know what's happening right now. Now you're like, oh my God, he's wearing shorty short. Like what? I'm wearing them right now. Shorty shorts. That's incorrect. I'm wearing my Superman pajamas, okay? All right, so, all right, let's be serious for a moment. So when we breathe in, we are contracting the diaphragm to move inferiorly, the external intercostals to move up and out with the rib cage. What do we do? I'm going to answer it for you here because we got to move a little bit faster at this little last portion here. If we want to expand the container more, okay, why would we want to do that? Well, it's a pressure thing. If we need to get the pressure lower, then we need to expand the container more, correct? Yes. So how do I do that? Well, these are skeletal muscles. We go back to 201. How do we contract the skeletal muscle more forcefully? We recruit more muscle fibers. If I lift this, it doesn't take a lot of muscle fibers. If I turn that into a 20-pound dumbbell or a 50-pound dumbbell, as the weight gets heavier, I have to increase the number of muscle fibers I recruit to generate more force to lift that particular object. So it's the same thing for inspiratory muscles. So if I want to breathe in and expand the container more, I'm going to contract the external intercostals and the diaphragm by recruiting more muscle fibers in those skeletal muscles. Now, if we go back, let's go back to the slide that talks about forced inspiration. Yes, we recruit more muscles from the diaphragm, or muscle fibers, I should say, or motor units, which are the nerves with the muscle fibers. We recruit more of them. We also do the same thing for the external intercostals. But to get maximal inspiration, we're going to recruit these other muscles, the scalenes in your neck, the SCM, and the pec minor. Okay, those muscles will contract to pull the rib cage open just a little bit more. Okay, so those muscles. So let's say we're talking test questions. If I say what are the muscles that are active during normal inspiration, you're going to say diaphragm and external intercostals. If I say what muscles are active during forced inspiration, you're going to say external intercostals, diaphragm, but also scalenes, SCM, and pectoralis minor. Okay. Now, how about expiration? What muscles are active during expiration? Normal expiration, none. Okay? So we go like this. This was atmospheric, right? We go, that's my contraction of the muscles. Expiration, I relax them. So normal expiration is simply relaxation of the diaphragm and relaxation of the external intercostals. So if I put on a test, what muscles are active during normal expiration? The answer is none. We're relaxing the ones that we contracted for normal inspiration. Now, let's fast forward here. Let's go to the slide that, where are we? Go to the expiration slide, and down at the bottom, it talks about forced expiration. Now, normal expiration, I just said, we're relaxing the ones that we contracted during inspiration, right? Forced expiration, we're going to recruit other muscles to make the container even smaller. Now, the external intercostals, these are the fibers. Now the external intercostals, the fibers going this way, they're going to pull the rib cage together, okay? Doing what? Making the thoracic cavity smaller, making the what? The volume smaller, making the pressure go up, okay? That's forced expiration. So what other muscles are going to do that? Abdominal muscles, specifically obliques, transversus abdominis, and then your internal intercostals. I've got that on your notes here. I have oblique, transverse, and internal intercostals. Those are the muscles that are active during forced expiration, normal expiration. No muscles are active. No soup for you. All right. So let me see if we got any questions on that. We're going to talk about the atmospheric pressure in a second with this altitude in a moment. No, we're good. All right, let's just keep going. If you have questions, throw them at me. We're almost done here. So here's the deal. If you go up a mountain, you are going up in altitude. Does the atmospheric pressure go up or does it go down? As you go up in altitude, the atmospheric pressure drops. They're in inverse proportion. As I go down in altitude, the atmospheric pressure rises. Okay? Now think about this. What did we say? We said atmospheric pressure intrapulmonary. We said in order to get air in, I've got to get the atmospheric pressure lower than the intrapulmonary pressure lower than the atmospheric pressure, right? Because it goes from high to low. If I'm climbing up a mountain, okay? I'll get that question in just a second. If I'm climbing up a mountain, what's happening to the atmospheric pressure? As I go up in altitude, the atmospheric pressure is dropping, okay? Make sense? So if I have to get below, as the atmospheric pressure drops, I have to expand the container more, right? So this is actually, yes, there's less oxygen available at higher altitudes, but it's also about the pressure. As I go up in altitude, my atmospheric pressure gets lower and lower. So I have to breathe, right? I have to contract with more force and recruit those muscles for forced inspiration because I have to get the intrapulmonary pressure lower in order for air to go from the out to the in, and this should make pretty good sense. If you were up, why do they pressurize a cabin in a plane? They pressurize it to give you a simulated atmospheric pressure at around ground level. Okay, I mean, your ears pop, so it's not exactly ground level pressure, but they pressurize the cabin for that reason. If you were to go up into the atmosphere at whatever 30,000 or so feet, whatever the cruising altitude is, you wouldn't really be able to breathe, okay? So, and it's because of the atmospheric pressure being so much higher at those altitudes. You're not able to, well, let's go back to where we were. You're not able to, so if it's so low, you can't get the intrapulmonary pressure lower, you're not gonna be able to breathe. So the good news is, if your plane splits in half at 30,000 feet, you're not gonna hit the ground alive. You'll suffocate before you get there. That's super morbid. I'm kidding, but it's true. That would happen. All right, let's ask this question. So diaphragm and external intercostals are active during normal inspiration, but none during normal expiration. You are correct. That is a correct statement. All right. And don't worry, your plane's not going to split apart. Plus, you're not going to be on a plane for a while. Damn you, coronavirus. All right. I think I want to stop there for material today.